Hi, good evening. I'm Dr. Philip Macmillan. Thank you for joining me. Can you believe that trust in doctors has fallen off? This is a study from the USA, maybe 30% since 2020, all because of COVID. Incredible. The question is why? What is it that has happened? How can it be rebuilt? Because this is very significant in terms of the way how patients and their clinicians interact. So what I've got today is it's just going to be a quick chat looking at the paper. I've had the pleasure of Dr. on to help me to dissect it. He's come on just on the spur of the moment, so he hasn't even seen the paper, but he'll add perspective and he can stay with me for a short time. But it's an important point and something that we need to address. Before we start, I'd quickly like to mention that we have coming up is our newsletter. Please subscribe to it. The link is in the description below, and you get a free ebook about nitric oxide. And coming up as well in the next few days is Navigating the COVID Storm, Therapeutic Options. This is about spike-triggered autoimmune response mechanism, a concept that you may not have heard about, well worth the time for you to reflect on it. And again, the link is in the description. So without further ado, let's add Rob to the stage. And hi, Rob. Thank you very much
Hello.
for joining me. I'll ask you to do a quick introduction, 20 seconds of yourself.
20 seconds, I'll make it 10. So
Yeah.
my name is Robert Goddard. I'm a oral and maxillofacial surgeon. I've known Philip for a number of years now. And I've been following the work that he's been doing with COVID quite avidly, having also tried to get a social movement called Touched by COVID in the throes of the pandemic.
Excellent, excellent. So listen, Rob, so thanks for joining me because I was just going to chat about this, but it helps to have some perspective. And what happened is that this was a JAMA paper that came out. And this is it here. So they were looking at trust in physicians and hospitals during the COVID-19 pandemic in a 50-state survey of the USA. So this is all here. It was recently published, and I just highlighted a few things here. So in terms of the design and participants between April 1st, 2020 and January 31st, 2024. And they looked at about 400,000 unique respondents between age more than 18 years old. And so they did just simple models, questionnaire-based study. And this is the important bit in terms of the results. It says, overall, the proportion of adults reporting a lot of trust for physicians and hospitals decreased from 71% in April 2020 to 40% in January 2024. That is absolutely huge. So you're just seeing those numbers for the first time. What's the first thing that goes through your head?
So obviously it's a study that's based in America. So I think we have to be cautious about extrapolating that information into the British context.
Yeah.
So from a British point of view, we're very much have an NHS system that predominates with a very small private sector. And it'd be interesting to know in that study what that kind of breakdown was between the predominantly private physicians versus the I don't know. I think they have what's it called?
Medicare. Yeah, the Medicare and so on.
Yeah.
It's a very important point, actually, and because the US, as we said, very different parts of the world, but in the USA, because it is primarily insurance-based and private-based, it is likely to be different impacts across the world. But my question is, would you be surprised if there was a significant drop-off in terms of patient trust for doctors after COVID-19 within the context of the UK?
Okay, so I think one of the things, that point I made about NHS and private is very significant because I wonder whether Americans see their doctors as being somewhat complicit in terms of, as an example, vaccinations and government policy, versus not being thought of as being the same in the UK.
Possibly, possibly. And when we look at the paper here, this is the breakdown now in terms of actual. I'll make it a little bit bigger here. Let's see if I can get it a little bit bigger here. So when they looked at gender, so orange is male, green is female, and you can see right at the start they're about in the same spot, and you can see this tail off for men, but even more significantly for women over the period of time. That in itself is quite interesting. Why women, even early on, started to lose trust in the system. And this would have been in 2020 before the vaccines. But then when vaccines came out, it really started to go down. The other thing that they did is they broke it down according to ethnicity. Other and you can that looks about the same trend going through. The one that I think stood out was in terms of age category here. So at the top here, the gray line is over 65s. And look at this, it was over zero point 0.8, almost over 80% at the beginning, stayed steady up until 2021, then started to shift down. But by 2024, they are down to almost 50%. That is a huge, significant fall off as well. The younger people, less interaction, was lower. It still went down, but I think this age group, because they interact with the system quite significantly, that is very, very concerning. That this the loss of trust that could occur over that period of time was so significant.
One of the other things that comes to mind is the respondents feeling empowered to question, and in terms of jeopardy if they actually raise their heads. And I wonder whether that is a bit of can account for the differences between men and women. If men are in jobs that effectively they can get fired from, versus women who might not be in that position and feel, well, actually, there's not much to lose. But the bigger question for me is, in this, and probably the study will elaborate, is what do they mean by a drop in trust? Trust in what regard?
Yeah, so I'll bring up in a second the actual kinds of questions that that they did. Let's just take a quick look. This is from the supplementary report. So pertinent survey question text. So it's questions like, how much do you trust the following people and organizations to do what is right? Hospitals and doctors, a lot, some, not much at all, not at all. How
I'm
much do
sorry,
you?
sorry, can I just interrupt? I think it's really important when you do have questionnaires that you don't put two questions in the one question.
Mhm.
And that question in itself has people versus the organization.
Yes,
And
yes.
whether that gets weeded out later on in the questionnaire, that's to be seen. But I would argue that is not a particularly good question.
Yeah, yeah.
And if that is representation of the whole questionnaire, I think there's problems
There's
in terms of
problems with
interpretation.
the methodology.
Yeah,
Good point. And what I wanted to show you is that I wanted to show you some of the comments, because sometimes the comments are quite significant. So look at some of the comments that came out in the free text when they did the study. So one thing, financial motives over patient care.
exactly.
So this includes perceptions of healthcare as primarily profit driven, where financial incentives outweigh patient
Agreed.
welfare. Now, the question is why would this drop have such a significant change in and around the pandemic? Was it that, what was it in the American landscape that could have done that? Was it the use, was it the protocols in COVID-19? Was it the mandating of vaccines? What could have done this significant fall off in patient trust? Any thoughts?
Well, with this point, I think potentially there can be transference into the UK system because you could argue, well, what governmental policies and hospital policies were in place, and is there trust in that in that process? And certainly, in that stage of the pandemic in 20, there was very much an argument. I think later on in 20 versus the beginning of 20, when everyone's thinking about lives matter, people started shifting towards the economic impact. And I think that might have something to do with erosion of trust in the healthcare system, not necessarily within the for the individual doctors. I'm not too sure how much power the general public perceive their doctors to have versus the overall system equivalent of our trust, hospital trusts.
It's an important point, and I think that realistically, that for many people, they perceive that the doctors, the clinicians control what happens in the system. They don't realize that it is very top down, driven by protocol, and that there is very little leeway in first world countries for doctors to do anything outside of a protocol. And so when things go wrong, it is quite normal for them, therefore, to think that the doctors are at fault. I usually use the analogy to the police. If you're hearing about issues with the police force, you don't differentiate whether or not it's the senior police officer, the sergeant, the detectives. You just look at the police force as being an issue. And I think that the public tend to do a very similar thing, which is why I was saying it was so important for doctors to be patient advocates rather than be appearing to be pharma advocates. This is one of the worries that I had, is that there wasn't enough questioning. They took everything as, this is it. No, no, no. Their responsibility is to advocate for patients all the time, not just initially. I'll show you another because
I think just staying on that point, I think that's what's interesting about the American system in contrast to the British system. I think if you think about some of the issues that have gone on in America with regards to, I know, the prescription of opiates, where the clinicians have more control about doing that. You do that in the UK. No, 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 no. It's very, very strictly governed what you can, can't do. So maybe if this research was repeated in the UK, that we'd actually find that actually the distrust is more directed at the systems in the UK versus the individual clinicians in America, because of the perceptions by the public in terms of how much power the clinicians have.
Yeah, I'll show you another point here. Um, Poor quality care and negligence. And the responses that mention experiences of neglect, inadequate care, misdiagnosis, dismissive attitudes from healthcare providers fall under this category. And this also includes perception of healthcare professionals not listening or taking patient concerns seriously.
I
And,
think
and
just holding on this one is this patient care and negligence. I think one of the points about the pandemic is how did the general public perceive the actions of clinicians in terms of their diagnosis and treatment for those people with COVID, with diagnosed COVID. And I don't think that the general public forget the fact that actually you get COVID, there's not much you can do about it, was the message. And therefore, I think it then raises the point, well, if, if clinicians can't deal with COVID, are they going to be able to deal with everything else?
yeah, I think that's a really important point, and I said it recently, is that I think what has happened in the pandemic is that we had a stripping back of the veil. There's a lot of stuff that happens in medicine our patients just weren't aware of. They didn't realize that doctors didn't have all the answers, and doctors kept that veil of we have all the answers so that people feel more comfortable when they're being treated. what then happened in the pandemic is that you had this very strange thing where people are saying, hold on there, what do you mean you don't understand? I can understand you don't understand in the first month, but beyond that, what do you mean? 4 years down the line, they still don't understand. Now, how in the world do you then go back to patients and say, well, we may not understand this, but we understand everything else? How does that work?
Um, I think you have to ask the general public about that one. Certainly, as a member of the general public with medical qualifications, I think I've always been aware because of going through the medical learning process that things aren't just black and white, and that when you publish a piece of research, you have to analyze it, and there'll be positives in it and there'll be negatives in it, and it cannot be taken purely on face value. In a way, I would say it's actually quite dangerous to give um, difficult research papers to the general public without any context. And it could be argued that that's patronizing and you're not giving people opportunities to understand what they're reading. But I can tell you, most physicians, when I say physicians, I use the term loosely in terms of doctors, struggle to read most academic papers and interpret it correctly. And that's
Mhm.
why we have peer review so that hopefully somebody does it for us. The process and the system of peer reviewing, that's the question. Was that a trustworthy process? I have every trust and belief that the vast majority, because if you think about theory X, theory Y, I'm a vast believer that people want to do good and people want to work hard and they want to do things for society. And that if something does go wrong, it tends to be that the system's at fault. Now, I get it that sometimes people think of, I'm not even going to use the word because I hate it, beginning with the C. And with, in a politics point of view, people might talk about, the deep state, and in terms of is there a higher power sort of looking over some malignant power? But I do believe very passionately that clinicians want to do the best for their patients, and they try very hard to do that. Whether
I would agree. And I think one of the difficulties is that because it's quite remarkable they fall off. So if you remember in early 2020, when people were dying, didn't know what was going on, and the clinicians, doctors, nurses, staff had to go and face the pandemic, they were considered heroes. And then suddenly now, this has taken a precipitous fall over the next 3 years with regards to how the public perceives those initial actions. And so I would say that what people can trust is that when the going gets tough, the clinicians will actually go and risk their life and limb for the patients. That's one of the things that came out of the pandemic. Even when they didn't know, even when they were scared themselves, they still went front line to face them. But here is the question that I think is very relevant. And as a whole grouping, as clinicians, we have to now ask this question because it impacts on us directly. And it's this: the other point that they raised was the influence of external entities and agendas. And so here, the focus is on the belief that decisions in healthcare are unduly influenced by pharmaceutical companies, government entities, or other external powers. This includes suspicions of dishonesty or withholding information for non medical reasons. So that C word, that conspiracy word, is a real impact with regards to what public perception is. And you know what is very frightening is that because largely the clinicians have been silent around all these things, the perception of the public is that they must therefore be involved when they have no idea. They just want. Any thoughts about that, Rob?
Well, silence or silenced. I think that is a very key point. Um, and
I think we just got stuck there with Rob, but I think he made a good point, which is were clinicians silenced or were they silent? Sorry, Rob, you're just going off for a second there. We'd
Yeah,
love.
sorry, my internet doesn't seem like it's like to
Yeah, so you had
function.
said something there about were they silenced or were they silent? What do you?
Exactly. So I think that
Yeah, somebody, oh, this is a good example of somebody jumping in and controlling what he's saying before he says it.
yeah.
Whatever you're saying there, Rob, they don't
Let
want
me
you to
let,
say
let me say it quickly. So, so we're going through a COVID inquiry here in the UK. It's probably going to be happening all over the place. The question is, what's going to come out of those inquiries? And there's an important point. Everybody feels that they have some responsibility in terms of what.
And he's right again. Everybody does have some responsibility with regards to what has happened. That's a nice look that he has there with his lips pursed and he's frozen at that point. uh,
And because we all have responsibility, it makes it very awkward because nobody wants to say, well, actually, we did it wrong.
yeah, absolutely.
Because
Hmm. It comes with a cost. Look at this here point, discrimination and bias. So responses indicating experiences or beliefs that healthcare providers exhibit bias, discrimination, or lack of cultural competency. This can include racial discrimination, gender bias, or insensitivity to patient backgrounds. And I think that a lot of this came out when we had this challenge between vaccination and on the vaccinated versus the unvaccinated. And did the clinicians do enough to protect the rights of unvaccinated people when this was going out that they shouldn't have the same kind of treatment? People should be left to die if they got sick if they weren't vaccinated. And the silence that happened, I think, from the clinical community was a problem because it's similar to saying that if people are obese or if they smoke, don't waste money on them. It's that kind of thing that came across. And any thoughts on that?
um, yeah, so I think that with regards to the whole speaking up, there's a perception that it's the commissions that actually drove the process and had the power. But in reality, policies were handed down from on high, and it was obey or get fired, obey or get ostracized. And there are plenty of people speaking out. I think you've done many of podcasts and programs all around the world. There are plenty of people speaking out about the way that things were done during the pandemic, but they were silenced, and you weren't allowed to say anything. And it's the same thing for the clinicians. And the narrative from the various governments, I think, was ingenuous by saying, led by the science.
Mm,
Science
yeah,
did not lead the policy. The policy did the government created and carried out the policy that they wanted, and they kept on saying, "Oh, but we were being led by the science." It wasn't being led by the science.
it was being led by the politics.
Yeah.
Yeah. Look at this here. This is a bit more of a breakdown of the influence of external entities. So this is exactly what somebody had said. They'd be denying healthcare to those who refuse the COVID jab. The media makes them tell us what they need us to hear because they told what to tell us. They are told what to tell us. It's just, it's true. And I believe they are all controlled by a higher rank of power. And what's interesting about all of this here is that so clinicians will say that's not true. But I thought to myself, there is such a powerful culture around guidelines and about evidence-based medicine and the fact that people are at risk if they do anything outside of what is considered standard evidence. And the fact that what I observed is that clinicians did not feel comfortable to be creative in the context of not having answers. And what I'll say here may sound strange, but I know it's true, is that it was a situation then that it was safer for clinicians to, if we didn't know, to let people die than to try and go outside the box to treat patients. When you see what happens to Dr. Shetty, saved so many lives, what is the outcome? He is being challenged to lose his license.
One of the things in any society, I find it's interesting. How do we choose our leaders, and what I'd say our sub leaders? Ultimately, those at the top chose people in their own image and who would be yes men. They did not seek leaders within the health service that were going to challenge any of the ideas, and that also included the research and how to deal with the pandemic.
Yeah. And it raises some serious problems because, as you said at the beginning, and I think it's important for people to remember that for the vast majority, I can't even think of a doctor I've come across who doesn't actually fundamentally have the patient's interest at heart.
No,
They all are concerned about their patients. But we have a system that is so rigid and so directed that it doesn't allow the flexibility for people to operate outside of that very tight regulation. And people, and in this sense, I don't think patients realize, or families, every time they do litigation and every time they make a huge fuss, they make it harder for people, for clinicians to take risks on behalf of patients. And so that issue about litigation is such a big one. And that comes from the families, that comes from the public. And so the public want this veneer of safety where everything is being done as it should be. But that comes at a cost in terms of restricting what clinicians do to keep you safe within guidelines.
narrative. What I would say is, if every time you hear about a clinician working outside of the box, it's usually a negative.
Yeah.
And and in the UK, probably since the likes of Harold Shipman, that's the biggest working outside the box. All the processes, all the appraisal systems are to get people to be uniform in their behaviors, in their actions in terms of carrying out their clinical practice. But it's a bit like research in any
I wish that he hadn't lost that
sorry
point. That was
distortion.
such an, yeah, go ahead.
Research ideas now, and you try and write a research paper.
Yeah, sorry. It's sad that he's getting some interference there with his internet. But what he was raising the point on there, which is so important, is that certainly when we have these very strict guidelines around appraisal. Sorry, Rob, you jumped off, so I just started talking. You dropped off. The appraisal system and the revalidation system has tremendous value for clinicians, but at the same time it puts such a restrictive restraint around creative practice that that will have an impact on the longer term for patient health and bringing up solutions. So most of the research that is being done now is being done through big pharma. The
Yes.
clinicians at the front are not doing research, and so therefore the only novel things that are coming through at the moment are therefore coming through big pharma, and therefore it means they can only be pushed if they have a financial incentive. So all of these things together mean that we have an absolute nightmare of situations where I think, I don't even know if we have recognized that this very tight regulation may work when everything is going well, but it doesn't work in the context of a pandemic. Are you still with us, Rob, or you've lost your signal again?
Yeah, it's coming and going. I think for your program, I probably better um, um, just remove myself from the conversation today,
Yeah.
and we will catch up again. But it's been absolutely fascinating to talk.
Yes. So yes. So thank you, Rob, for being with us. And as I said, this was just a quick catch up for people, so that you would then have an idea as to some of the research that is going on, and just to remind you all that what we have at the moment is a situation where we had a pandemic, or we still have an ongoing epidemic in highly vaccinated regions. We need to be creative, because the solutions that are required are not in a box. They're not easily just pulled out. And one of the problems we have now is that we are facing a situation that was not anticipated. And this is how I describe it, based on what was happening at the time, the community, that if we vaccinate, therefore, the whole population, we would stop the pandemic. But they didn't understand the science that it wouldn't stop transmission, and that the effects would wear off after a period of time. So what we have now, study, and a challenge study is usually done in research, where you would vaccinate the animals, say, wait for the immune system to be properly set. And then what you do is you re-expose them to the virus to see whether or immune pathology. When they did this with SARS-CoV, and they used a number of vaccine platforms, every platform was associated with lung immunopathology. And so therefore, what I don't think was anticipated is what does that look like? And that's effectively what I'll be talking about quite soon, which is, as I said, navigating the COVID storm. And this is what we'll be looking at. What is the COVID storm, the spike triggered autoimmune response mechanism? Why is it occurring in relation to recurring infection? And how can we try and mitigate those pathological impacts that I think are occurring all the time? There's still huge challenges ahead. And the loss of trust that has occurred over the pandemic, I trusted the science at the time, only to realize that that science wasn't fully explored. And therefore, they are caught in a situation where, what do we do now? Who is going to step forward and say, well, that was, we didn't fully understand. Maybe if we were doing it again, we'd do it differently. Should we have used mucosal vaccines? Should we have only concentrated the vaccination to just the high risk and let herd immunity take its course, as what happened in many poorer countries who didn't have the number of vaccines as they did in the first world? And I keep on reminding people that in many countries across the world that are only 30% vaccinated, you do still have circulating virus in bubbles, but for the vast majority of the population that has herd immunity, this is over. And so now it's a difficult time. It requires more creativity. It really requires the clinical community to be thinking on their feet, to be looking for solutions, to be trying their best to find answers. And without that occurring, it will be difficult. And I'd say, I don't want to say a disaster for patients, but that's what I'm worried about. And this is why, as I said before, I am focused on this concept, storm. This is a new idea, new concept, bringing the science together, and in effect, trying to anticipate what is going to happen next. Join me on that journey. And as usual, look out for the ongoing presentations as we continue to build the science, trying to find answers. Let's rebuild the trust. Have a great evening.